Thanks for joining. Can you give me a heads up if I'm audible or not? Thanks for joining. All right, I think I'm audible. So we are going to wait for 1 more minute and then we're going to start the session. So today's session is all about gastrointestinal physiology, and I'm just keeping this session to be up to the basics, or it would have been gone at a very great extent as well. So अभी के लिए I have about 150 slides that we have to cover, and we're going to cover that in slightly at a थोड़ा सा faster speed. Okay. So I think we have people here. So I'm going to start right now. So let me just begin by telling you something about the layers of the gastrointestinal system. As you all know, that the outermost layer is known as the serosa, right? So this is the serosa that we have, and this is about what is that? It basically modified visceral peritoneum. Just remember for an MCQ that all of the GIT has the serosa except in the esophagus. In the esophagus, we have something known as the adventitia. Just below the serosa, you might be seeing you have the muscularis externa, which is made up of an outer longitudinal muscle and an inner circular muscle. Okay. So whenever the longitudinal muscle actually contracts, what is that going to lead to? This is the GIT, it's going to lead to shortening of that segment. Okay. And whenever the circular muscle is going to contract, what is that going to lead to? It's going to lead to narrowing of that segment. Okay. Between the outer longitudinal and the inner circular muscle, we have something known as the myonteric plexus. Okay, so we have something known as the myonteric plexus, which is going to do something about the gastrointestinal motility. Okay, just remember, in case of the stomach, we also have the innermost oblique layer. Okay, stomach may additionally we have the oblique layer. Now, just beneath the muscularis externa, we have the submucosa. So this submucosa is made up of loose connective tissue, and it has multiple glands. And very importantly, it has a plexus, which is known as the submucosal plexus, also known as Meissner's plexus, also known as Orbach's plexus. Okay, so this plexus is going to be about intestinal secretions. And then obviously we have the blood vessels running beneath as well. Now, the last layer that we have is actually made up of three components. We have the epithelial cells, that is the enterocytes. The below the epithelial cells is your lamina propria, and below that is your muscularis propria. Okay, not your muscularis propria; it's the muscularis interna, or I could say the muscularis mucosa. Okay, so these are the layers. So we have the mucosa, we have the submucosa, we have the muscularis externa, and we have the serosa and the adventitia. Now, moving forwards, just as we were discussing in neuromuscular physiology, the gastrointestinal system, or in fact any hollow visceral organ, is mainly covered by or mainly supplied by your which type of smooth muscles? They are known as single unit smooth muscles. Why did we call them as single unit smooth muscles? Because ये सारे के सारे smooth muscles जो हैं, they're connected to each other by these gap junctions. And we went in detail how these gap junctions are made up of proteins known as connexons, right? So what are they going to do? They're going to contract as a syncytium. Okay. So what are these muscles? Single unit smooth muscle cells. Okay. Now, talking about the electrical activity which is present in the GIT, okay? So we're going to discuss three types of electrical activity. First thing that I want to turn your attention to is the slow waves and the myogenic wave. I think you would remember the single unit smooth muscle cells. They only need neural input only for modulation, but they're primarily myogenic. मतलब उनको कोई और supply की जरूरत नहीं पड़ती है. So what are these slow waves? These slow waves are due to something known as your fluctuating resting membrane potential that we saw in case of smooth muscle cells. So this resting membrane potential is actually fluctuating. Okay. And we don't know the reason why, but when we talk about the slow waves, we should remember that they're not action potentials. Okay. So they're going to be sub threshold hamesha, and they're not action potential. So if they're not action potential, if you might remember, the smooth muscle cell ke case mein the action potential was calcium. So there is no calcium entry over here. So because it's not an action potential. So the main channel which are responsible for this are your sodium channels. Okay. So it's mainly sodium influx that we're talking about in case of slow waves. And what are the origin of these slow waves? We have the interstitial cells of Cajal. Okay. So these are the origin of these slow waves. They are known as the pacemaker cells. Just like we have the SA node, just like we have the AV node, the autoexcitable cells. इस case में GIT के case में we have these cells. So हर GIT के अलग-अलग portions में these interstitial cells of Cajal are there, and they're going to generate these slow waves. हर portion of the GIT has something known as the basic electrical rhythm. मतलब कितने per minute that slow waves is going to be generated. Okay. So what is that? If you look here, the esophagus in the proximal stomach does not have any basic electrical rhythm. Okay. When we talk about the mid stomach, it's 4 per minute. The duodenum is 12 per minute. The terminal ileum, it's 8 per minute. The cecum, it drops down to 2 per minute. And if you look at the sigmoid colon, it again increases to 6 per minute. So what are these? These are the basic electrical rhythm. है ना? And the interstitial cells of Cajal, they're absent in esophagus and proximal stomach. That is why the basic electrical rhythm is not present in case of the esophagus and the proximal stomach. Okay? Right. So just remember the interstitial cells of Cajal के पास एक sodium, एक special type of channels हैं. They're known as slow opening calcium sodium channels. So they're both calcium as well as sodium. If someone asks you which is the predominant ion here, so the ion that is predominant is sodium. Okay. So what next? We're going to have something known as spike potentials. So these are the actual true potentials. Okay. So whenever the slow wave it reaches to a potential of minus 40 millivolts, then we say कि threshold reach हो गया है, and now the voltage gated calcium channels might open, and you might see something known as an action potential in case of a smooth muscle cell. And this is obviously going to be followed by contraction of that segment. So these are known as spike potentials. So these action potentials are generated by the opening of which channels predominantly? It's mainly the calcium channels. And calcium may be कौन से? Either we have the voltage gated calcium channels or we can have the calcium sodium channels. Okay. Just remember one more thing कि जितना ज्यादा आपका जो ये स्पाइक पोटेंशियल ऊपर की तरफ गया है, whatever that depolarizing wave is, जितना ज्यादा उसका एम्पलीट्यूड होगा दैट मच अमाउंट ऑफ फ्रीक्वेंसी यू विल गेट, एंड दिस वाज नोन एज फ्रीक्वेंसी कोडिंग जो हमने पहले की बात की थी, बिकॉज एक्शन पोटेंशियल का एम्पलीट्यूड इज गोइंग टू रिमेन द सेम. Only thing that is supposed to change with the amount of threshold that you apply, with the amount of stimulus that you apply, is the frequency of the generation of that action potential. So let me tell you something about that. So these are the slow waves. If you see, they're always below minus 40 millivolts, which was the threshold. Once the threshold is crossed at minus 40 millivolts, we're going to have generation of these spike potentials. They're known as action potentials. Okay. And whenever, if you see, whenever the slow wave potential ka amplitude is increasing, see, this case में the amplitude is less as compared to this one. What is increasing? If this was 2 per minute or something like that, 2 per second or something like that, now we are seeing that there are much more amount of action potentials being fired just upon the simple fact कि अब ज़्यादा आप stimulus provide कर रहे हो. So that was known as frequency coding. Okay. So what are the things that can depolarize the membrane? Muscle stretch, a very important thing. ठीक है. तो we know कि जो हमारा जो enteric nervous system है, that's a little brain of its own. ठीक है. It can function independently. So that is the thing. Muscle stretch जब भी आएगा, that's going to depolarize the membrane. What about acetylcholine? Acetylcholine is obviously parasympathetic nervous stimulation, and we know parasympathetic rest and digest. Okay, so that's going to stimulate muscle contractions and depolarize the membrane, make it more positive. And obviously, we have some specific GI hormones which we're going to talk about. What are the factors which hyperpolarize the membrane? I just want you to remember the sympathetic nerve stimulation. Okay, so that is what is happening, and we saw all of the different tables. Okay, so now smooth muscle cell can actually contract in two ways. We can have either something known as a phasic contraction, मतलब contraction आया and then it dies down. Okay, or we can have something known as your tonic contraction. Tonic contraction is high intensity, continuous contraction without any relaxation in between. So this is like contracting then relaxing, contracting and relaxing. So this is known as phasic contraction in case of smooth muscle cells, and this is your tonic contraction. So now we were talking about the gut-brain axis, and we know that there is something known as the enteric nervous system, which plays a very important role. The sympathetic nervous system mainly plays a modulatory role. Okay, so the enteric nervous system is the main one. Okay, so what are they? The enteric nervous system, when we try to study two plexuses. Okay, it's also known as the peripheral brain, also known as the mini brain. So the two plexuses are, पहला तो हमने एक देख लिया, that is your mynteric plexus, also known as your Orbach's plexus. Okay, that was lying between the two longitudinal layer and your circular muscle layer. Okay, this was the mynteric plexus. What were it doing actually? It was the one which was controlling your motility. And what about the submucosal Meissner's plexus? It is present in the submucosa. Okay, and what does it control? It controls two things, that is your secretions and your local blood flow. Okay, so now what are the different neurotransmitters do we have? So we have different types of neurotransmitter. It would be very helpful if you remember that. We have excitatory neurotransmitter in the enteric nervous system, or we can have inhibitory neurotransmitters. What are the excitatory neurotransmitters that I want you to remember? Is your acetylcholine, your substance P. Okay, mainly these are the ones which I want you to remember. These are your excitatory neurotransmitters. What about inhibitory ones? I want you to remember nitric oxide and vasoactive intestinal peptide, NO and VIP. So these are the inhibitory neurotransmitters. Why are we discussing them? I'll tell you shortly. So as we know, the enteric nervous system can be controlled by a sympathetic nervous system as well as your parasympathetic nervous system. Okay, but just remember the autonomic control is only an influencing or modulating system. Okay, Varna it is dependent on its own. So what about the sympathetic nervous system that we have? So let me just turn your diagram towards here. So when we discuss about the spinal cord and हम जब उसके lamina discuss करते हैं, here we have something known as the intermediolateral horn. We are talking about what? We are talking about the sympathetic nervous system. ठीक है, thoracolumbar जिसे हम कह रहे हैं. तो यहाँ पे you have something projection known as the intermedial lateral horn, जिसमें से हमारे pre-ganglionic sympathetic nerve fibers come. You know this, we have studied this already. Okay, so these are the fibers which are running here. So now where do they go? I want you to tell something about the ramus communicants. Okay, so these preganglionic sympathetic nerve fibers, they have to reach here. What is this? This is the sympathetic ganglia. Okay, so this preganglionic sympathetic nervous system is going to be carried into the anterior root of the spinal nerve. It enters the spinal nerve now, and we have something known as the white ramus communicants. Okay, so this white ramus communicants is that portion of this structure which is carrying the preganglionic sympathetic nerve fibers to the sympathetic ganglia. Okay. What about the gray ramus communicants? Gray ramus communicants does the opposite. So sympathetic ganglia say post ganglionic sympathetic fibers, it's carrying on and supplying it to the glands. Okay, or to the GIT in this case. Okay. So just remember the white ramus communicants, it carries your preganglionic sympathetic fibers, and your gray ramus communicants, it carries your post ganglionic sympathetic fibers. Okay. So we know the origin in case of the enteric nervous system for your sympathetic nervous system is T5 to L5. Okay. All right. Just remember the sympathetic nervous system is a region which is innervated in the same density for the entire GIT. So there is no spatial differences per se. And the predominant neurotransmitter, as we know, is norepinephrine, because we know there's a sympathetic nerves there. They don't have that enzyme which was known as PNMT. We've discussed this. Okay. So sympathetic nervous system karega kya? It's going to decrease the motility. It's going to decrease the secretions. It's going to lead to constriction of the sphincter, as well as it's going to decrease the blood flow as well. Okay. So this is the role of your sympathetic nervous system. Now we're going to discuss something about the parasympathetic nervous system. So what is that? Origin क्या है इसका? Cranial हो सकता है and sacral हो सकता है. That is what we call craniosacral. तो cranial किस cases में? Till the half of the transverse colon. ठीक है? So esophagus, stomach, small intestine, till the half of the transverse colon, it's cranial. And later on, it's mainly a sacral. That is from the second half of the large intestine till the anal canal. What are the neurotransmitters that we predominantly release? It's mainly acetylcholine. Okay? And what's it going to do? It's either going to increase the motility, or it's going to increase the secretions, or is also going to increase the blood flow as well. Okay? Just remember, we're going to talk about this important neurotransmitter known as gastrin releasing peptide. Okay? We're going to talk about this because what I want you to emphasize is it's not only acetylcholine which can get released from the vagus. We can have something known as gastrin releasing peptide, also known as bombacin in case of amphibians, but हमारे case में humans में we call it as a GRP. Okay? So now this is what I was ये बहुत important slide है. What is happening is whenever you have a food bolus, and what it leads to is distension of that segment. Okay, so we have a process known as peristalsis. Okay, we're going to talk that in detail. Peristalsis का मतलब ये है, it is a propulsive movement. ठीक है, ये bolus को आपको आगे तक लेके जाना है. If you want that bolus to travel forwards, you need to do two things. You need to contract the segment behind the bolus so that it pushes it forward, and you need to relax the segment in front of it so that it receives it. Okay, so how is that mediated? Is via the enteric nervous system through the mynteric plexus. So what's going to happen is whenever you have distension, this is something known as IPAN. IPAN is the intrinsic primary afferent neuron. So what is this doing? It's basically an afferent neuron. It can detect stretch. Okay. So whenever there is distension, it can detect stretch. This intrinsic primary afferent neuron is going to stimulate the ascending. So what is this? Ascending and descending का क्या system है? Whenever it's towards the oral cavity, it's ascending, और जो भी bolus से ऊपर है, and whenever it is towards the anus or basically below, that is in front of the bolus, then that is known as descending. वो क्या करेगा? Ascending motor neurons को excite कराएगा so that they release excitated neurotransmitters, which were the acetylcholine and substance P. Okay, so that they can contract and push this bolus of food forwards. And what about the दूसरा ones? So this intrinsic primary afferent neuron is going to inhibit the descending motor neurons. Okay, so इसके कारण क्या होगा? There's going to be a receptive relaxation via which neurons, via which neurotransmitters? Mainly it is nitric oxide and vasoactive intestinal peptide. Okay, so this is what is happening. So this is what I want to discuss about the two movements that we have. We have peristalsis. This is your propulsive movement. This is also known as the mynteric reflex because ये सारा portion is going to be facilitated by the mynteric reflex. So this was what I was telling कि bolus आएगा, it's going to stimulate this intrinsic primary afferent neuron. जो इसके portion, that is the ascending portion of the gut को ये contract कराएगा, constrict करवाएगा via exciting the motor neurons by releasing acetylcholine and substance P. Whereas जो descending portion को वो relax कराएगा via releasing your nitric oxide, vasoactive intestinal peptide, or even neuropeptide Y. So this is what we have. We have peristalsis. Okay. So there is ascending contraction due to acetylcholine substance P, and there is descending relaxation due to these neurotransmitters. What does it depend upon? It depends upon the myelinic plexus. And it wouldn't hurt you to know that there is something known as the law of the gut. Law of the gut का मतलब है कि जो propulsion of bolus होएगा, that always has to be from the oral cavity towards the anal side. Okay, so that's what it is. So what about the other type of contraction is your something known as segmental contractions. Okay, segmental contractions is for your mixing movements. तो इस केस में क्या होता है? See, if this is the bolus that I want, I will contract here, right here, at the center of that bolus, so that it breaks down and basically वो break करके छोटे छोटे fragments बन जाएं, and then I can mix that. Okay, तो contraction waves ऐसे proceed करती हैं in case of your segmental contraction. ठीक है, and इसमें क्या हो रहा है? Basically both the ascending as well as the descending portion of the bolus जो भी है जहाँ पे they're going to contract, and ultimately जो bolus जहाँ पे है वो भी is going to contract. So what is happening is ये जो bolus ऐसे था is now going to be spread apart now. It's going to be broken down. So how is that going to help? Obviously that will increase the absorptive surface, है ना, वो पतला हो जाएगा, फ्लैट आउट हो जाएगा. तो एंड वी नो जो सारे एंजाइम्स होते हैं दे वर्क ऑन दैट सरफेस ऑफ दैट बोलस. तो जितना ज्यादा सरफेस एरिया होगा ऑफ द बोलस, उतना ज्यादा डाइजेशन में हमें एड होएगी. ओके, so when we were talking about this, we have to discuss something about the splanchnic circulation as well. So what it is, ये मेरा क्या है? This is a villi. ठीक है, it's a part of an enterocyte, and this is one of those regions of the body where we have something known as the countercurrent blood flow, just like the testes, just like your renal. So इस case में what is happening is कि सारे के सारे nutrients are either going into the lacteals, that is your lymph, or it is going directly into your blood capillaries. ठीक है, whatever be the case, everything has to reach the liver. ठीक है, liver we know कि liver के जो सारा का सारा splanchnic circulation है, it mainly goes into the portal vein by the superior mesenteric vein and your splenic vein. It joins to form the portal vein, and even your inferior mesenteric vein drains into the splenic vein. We know that. I'm not going to discuss abhi surgery or anatomical aspect of it. Okay, so इस case में what is happening is it drains into the portal veins, and then we know कि portal veins के through it's going to travel to the central venuole. Okay, so this is what happens. This is your splanchnic circulation. Just remember, जो blood flow होता है, whenever we talk about blood flow anywhere, we have to see कि क्या factors से regulate करते हैं. Just remember, in case of the enteric nervous system, the blood flow is directly related to the local metabolic activity. जितनी ज़्यादा activity होएगी, जितना ज़्यादा food होएगा, it's going to increase the blood flow उसी के accordingly. ठीक है? And how is it mediated? By the mucosa, that is the epithelial cells वगैरह, they can release something known as vasoactive intestinal peptide, which can lead to vasodilation of that the arterioles. What about the glands? Glands can release your very important your calodins as well as your bradykinin. They're again your potent vasodilators. And very importantly, whenever there is metabolic activity, तो क्या होगा? You're going to have a decrease in the oxygen tension. And जब oxygen कम होएगी, you're going to have decreased generation of your ATP, and ultimately your adenosine will increase, and we know that adenosine is a very important vasodilator. So these are the stuff which was actually leading to vasodilation of the splanchnic circulation whenever we have food in it. Okay, so this is what we know कि कैसे वो travel करता है via the portal vein into the liver, and then it drains into the inferior vena cava via the central venules. ठीक है. So what are the nervous system? अगर nervous system की बात करें on the splanchnic circulation, we should know the sympathetic nervous system decreases the blood flow, whereas your parasympathetic nervous system which actually increases the blood flow. ठीक है. But just remember, sympathetic nervous system इस करके वो decrease करता है blood flow because it has its receptor on the vasculature. Just remember, blood vessels के पास have only sympathetic receptors. They don't have any parasympathetic receptors. Okay. So in case of sympathetic nervous system, it's very easy via the vasoconstriction of the arteriole due to the alpha adrenergic fibers. In case of parasympathetic nervous system, it mainly says कि parasympathetic nervous system कैसे modulate करता है your blood flow is that it increases the activity of these glands. And whenever glands की activity increases, what is that going to develop? That's going to develop a drop in the oxygen tension, और उसके accordingly आपका blood flow बढ़ेगा. What we were talking about was the local metabolic activity. ठीक है. Next, we talk about the gastrointestinal motility per se, and we have some different things that we have to discuss. One thing is your mastication. Okay, mastication is both a conscious as well as your unconscious process. So इस case में क्या होता है? Whenever your bolus, when you have bolus in your mouth, it's going to stimulate your touch receptors, okay, which are present there. जब touch receptors stimulate होंगे, this is going to stimulate your reticular formation, okay. And whenever the reticular formation it gets stimulated, it's going to inhibit your muscles of mastication. So what's going to happen is your jaw जो है आपका वो drop कर जाएगा, ठीक है. And whenever the jaw drops, we know whenever a muscle lengthens, what's going to happen? It's going to increase the length of the muscle, and that's going to initiate the stretch reflex. Okay. And what are we going to have? We're going to have the contraction of the muscles of mastication. The jaw will again lift, and that's going to again come in contact with the bolus, and that's going to trigger this unconscious pathway. I'm talking about the unconscious control of your mastication. Okay, so the incisors, they basically play a cutting role, whereas your molars, they basically play a grinding role, and most of the muscles of mastication are mainly supplied by the trigeminal nerve. So where is the control center for your mastication? Just remember, it's mainly the brainstem reticular formation that we're going to talk about. But we have other centers as well, which we don't need to discuss for far. And what is the role of mastication? सिर्फ जितना हम chew करेंगे, that's going to increase the surface area of the food particles, है ना? So that's going to increase the rate of digestion. And the second is to form a bolus, okay? So that we can elicit something next which is coming up, that is a deglutition reflex. So let's talk about the deglutition reflex now. Actually, the deglutition reflex is actually a two-part mediated reflex. We can have the oropharyngeal phase, जो कि voluntary है, that is from the mouth till the hypopharynx, ठीक है? Then we can have something known as the involuntary phase, which is not in our control, that is pharyngeal as well as esophageal, extending from the hypopharynx till you empty the bolus into the stomach. So it's both a reflex as well as an unconscious act. Okay? It's a reflex act as well as a conscious act, both of them. Okay? What are the receptors which are mainly present for your this phase? This is your involuntary phase. So the concept goes like this. Till the pillars, that is your anterior and your posterior peroneal pillars, or your posterior lateral wall of the pharynx, जो आपका deglutition है, that's mainly a voluntary thing. Once it stimulates the posterior and the anterior pillars of the tonsils, what's going to happen is it's going to initiate this involuntary aspect of it. Okay, so these are the things which you talk about. कि receptors जो कहाँ present है, anterior and posterior tonsillar pillars पे हैं, and over the posterior lateral wall of the pharynx. What are the different afferent nerves? It's mainly the ninth and the superior laryngeal branch of the vagus. So these are the afferent. So there must be an efferent as well, and there must be an integrating center. The integrating center is in the middle oblongata, very importantly. And what are the different efferents? Efferents बहुत सारे हैं. We can have your muscles of mastication as well. We can have your ninth nerve, 10th nerve, 11th, 9th, 10th, as well as your 12th nerve that's controlling the tongue as well. So many different things are required. Okay. So what I have here is MRI sagittal scans. So this was proving to be much more helpful to understand the process of this deglutition. So what's going to happen first of all is, this is the tongue right here. So this tongue is going to elevate, and there's going to be a posterior movement of the tongue. Can you follow? Okay. So this is going to happen. First thing. Second, what you're going to develop is this soft palate right here. It's going to move upwards. Why is it moving upwards? Because we know that हमें ये food को nasopharynx के अंदर नहीं पहुंचाना है, ठीक है? So how do we ensure that? आप अगर soft palate को move up कर दोगे, it's going to contact with the Passamans ridge, है ना? It's going to contract with the Passamans ridge, and it's going to control that is present on the posterior pharyngeal wall, and इसके कारण it's going to seal the oropharynx from your nasopharynx. So that's the second stuff that happens. What happens next of all? The oropharyngeal हमारा जो ये वाला portion है, that also gets closed down. So you have the closure of the oropharyngeal isthmus. You have the upward liftment of the soft palate, which contacts with the Passamans ridge as well. So that closes as well. What next will happen is, this hyoid bone right here, that's going to lift up. So there is elevation of the hyoid. Obviously, there's going to be elevation of the larynx and the epiglottis, which guards the trachea basically, that leads into the trachea. That's going to close. Okay, so these are the stuff that happens. And ultimately, closure of the larynx, we're going to have cessation of the respiration as well. There's going to be contraction of the aryepiglottic folds, and your falls and your true vocal cords, they're going to come together as well. Okay, so these are the stuff that happens in case of your deglutition. Okay. All right. So what's going to happen next is, once you enter into the pharynx, if bolus आपका pharynx के अंदर आ गया है, there is one more hurdle, that is your upper esophageal sphincter. That is the hypopharynx, which it enters into the esophagus. Okay. It's going to be protected by something known as the cricopharyngeus muscle. So we know that there is something known as the cricopharyngeus, and there is something known as the inferior pharyngeal constrictor के ही ये दो parts हैं, that is the cricopharyngeus and your thyropharyngeus. So this cricopharyngeus over here is forming the upper esophageal sphincter. So this pharyngeal muscles, which are your inferior constrictor muscles, are going to contract, and this upper esophageal sphincter is going to relax. Okay. So what happens usually is, whenever you are at rest, ये जो hypopharynx है, just above the esophagus, that is at a pressure of about 30 millimeters of mercury, and this upper esophageal sphincter has a pressure of 60 millimeters of mercury. So there is no way that this bolus is going it's going to open on its own. But whenever you have a food bolus coming in, this vagus nerve, that's your 10th nerve, it's going to do two things. एक तो posterior जो हमारे sphincters हैं, constrictors हैं, sorry, उन्हें वो contract कराएगा, as well as is going to inhibit your upper esophageal sphincter का tone as well. So whenever this upper esophageal tone relaxes, it's going to drop down to 30, and your hypopharynx ka pressure is going to increase up to 60 millimeters of mercury, and then the bolus passes downwards. So this is your deglutition reflex. Okay. Just remember one more thing. Whenever we talk about the esophagus, Esophagus has actually two types of peristalsis. You have a primary peristalsis, there's a secondary peristalsis, and sometimes there's also a tertiary peristalsis. We're going to talk about the former two, primary and secondary. So primary peristalsis कुछ नहीं है. It's just like the swallowing आपने जो अभी कराई है via the swallowing center which is present in the medulla oblongata. उसी का continuation, it's being carried forward by the esophagus as primary peristalsis. So someone asks you कि swallowing it continues as your primary peristalsis. However, your secondary peristalsis is mainly due to the myonteric plexus which is present in the esophagus. So it's a local reflex. Okay, so it's a local reflex, not a CNS mediated reflex. So primary peristalsis is mainly a continuation of your pharyngeal peristalsis mediated by the deglutition reflex, whereas your secondary peristalsis is due to stretch related factors due to the triggering of the enteric nervous system that I'm talking about, the myonteric plexus. Okay, so now अब हम esophagus में आ गए हैं, and obviously the next hurdle that we have is the lower esophageal sphincter, and just like you all know, the lower esophageal sphincter जो है उसका भी एक अपना resting pressure होता है, that's about 10 to 25 millimeters of mercury, and it consists of two portions. You can have either the esophagus के जो muscle fibers हैं, some contribution is also by the oblique muscle fibers of the stomach, and the next one is your extrinsic, that is your diaphragm, जो pinch cock effect protect करता है, that is in your anti-reflux mechanism that we study it in surgery. Okay, so what's going to happen is now this lower esophageal sphincter is also going to undergo relaxation. Okay, is undergoing relaxation, and again this is mediated by the vagus nerve. So what happens is whenever the bolus enters at the lower portion of the esophagus, it's going to stimulate its afferent that's going to be carried to the spinal cord, ultimately to the medulla oblongata and to the vagus. And now the vagus kya karega? It's going to inhibit your LES as well as it's going to inhibit the cardia as well. So what's going to happen is esophagus या जो LES है इसका tone release होएगा, but जो bolus आ रहा है, we need to accommodate that bolus into the stomach. So the cardia also undergoes receptive relaxation, which we're going to talk about. Okay? So this is what is happening. So there are some stuff which is very important discussing कि LES pressure को कौन modulate कर सकता है. So there are some things which can increase or there are something which can decrease the LES pressure. What are they? Alpha adrenergic support. Alpha receptor stimulate हो रहे हैं तो increase होएगा. Substance P and cholinergic, obviously they're excitatory neurotransmitters, so they're going to stimulate it. Then domperidone and metoclopramide, okay? Antiemetics की तरह, they're going to inhibit this LES sphincter as well, and your gastrin. What about the decreasing the tone? It's mainly your beta stimulation or your CCK and your secretin, as well as estrogen and progesterone. That is the reason why it is more common to find it in pregnant female. That is your gastroesophageal reflux. You have VIP and nitric oxide, हमारे trustworthy inhibitory neurotransmitters. You have caffeine, very importantly, chocolate, as well as alcohol. Okay, so these are the things which can precipitate your gastroesophageal reflux. Okay, so we discussed about the deglutition as well. We discussed we have the oral phase and we have this phase. This was voluntary till the bolus touches the tonsillar pillar. Okay, uske baad it's going to be an involuntary phase. Okay, so now as we have discussed it, now we move on to the stomach now. Okay, so stomach ke paas kya kya uski motor activity we have to study in which sections is something known as relaxation and accommodation first of all. Then the stomach has something known as segmentation and contraction. It also has peristalsis and gastric emptying, and ultimately we are going to study about migratory motor complexes. Okay, what are the pacemakers for setting off this motor functions of the stomach? Again, the interstitial cells of Cajal. Just remember, interstitial cells of Cajal pathological aspect के लिए important है because these are the origin of your gastrointestinal stromal tumors. Okay, so what is the first thing? Receptive relaxation and gastric accommodation. What is this? अभी हमने पढ़ा whenever the bolus enters into the lower end of the sphincter, lower end of the esophagus, what's going to happen? That's going to stimulate the afferents, going to stimulate the medulla oblongata, going to stimulate the vagus, and what is that going to do? एक तो लोअर एसोफेजियल स्फिंक्टर को रिलैक्स करेगा, एंड दूसरा हमने क्या पढ़ा था? वी स्टडीड कि जो कार्डिया जो है दैट्स गोइंग टू अंडरगो रिलैक्सेशन, और उसे हमने क्या कह दिया? वी कॉल इट एज रिसेप्टिव रिलैक्सेशन. तो व्हाट इज दिस गैस्ट्रिक अकोमोडेशन देन? सिंपल फंडा है कि रिसेप्टिव रिलैक्सेशन इज मेनली मीडिएटेड बाय द सीएनएस. वी आर टॉकिंग अबाउट द मिडल ऑब्लोंगेटा, हायर इंटीग्रेटिंग सेंटर है, whereas this gastric accommodation is mainly mediated by our myonteric plexus only. वो सेम चीज रही है, दैट इज देयर इज फूड बोलस जो आ रहा है उसको जगह बनाने के लिए we need to increase the cardia needs to undergo relaxation. Okay, so that is what we talk about, receptive relaxation and gastric accommodation. Okay, and what was it mediated by? It was obviously mediated by the 10th. So whenever you have vagotomy, what's going to happen is आपका stomach is not going to able to accept that amount of bolus. ठीक है, so what we call it as compliance. Compliance is कि कितने easily for every per unit pressure how much you can increase the volume. So obviously whenever you have vagotomy, you're not going to able to undergo this receptive relaxation and accommodation, especially receptive relaxation, that is the predominant part, ऐसा नहीं है कि इन पेशेंट्स में ये वाला पोर्शन नहीं हो सकता, दैट इज गैस्ट्रिक accommodation can occur because it's a enteric nervous system mediated reflex, but predominant role is played by the vagus septum only. Vagotomy जब भी होगी, the compliance of the stomach is going to decrease, the intragastric pressure on the other hand is going to increase, है ना, as well as the gastric emptying. Whenever the intragastric pressure increases, your gastric emptying is also going to increase. So the second movement that I'm going to talk about is segmentation, contraction and peristalsis. हमने already segmentation and contraction के बारे में पढ़ लिया है. That is your grinding movements. ठीक है? So I just want you to focus on this diagram right here. So what's happening here is कि mid stomach में से somewhere you have this something known as peristalsis. That is your propulsion. All of this food contents are going to go forwards. But here we have the pyloric valve or the pyloric sphincter. This pyloric sphincter is closed right now. Okay? So this is the first mechanism that's known as propulsion. Now what's going to happen is, अभी ये जो pyloric valve है, again it is closed and now grinding is going to occur by something known as segmentation contraction जो हमने पीछे पढ़ा. So this is some form of peristalsis. This is segmentation contraction and now the thing is, the pyloric valve now slightly opens. बहुत slightly, okay? इतना slightly that only something known as the chyme can go through. What we were talking about was the bolus, okay? This bolus needs to get broken down into chyme. This is chyme is a semi-liquid, semi-solid is की consistency, liquid-like consistency. So only that portion of your gastric contents can pass through. What about the other ones then? Then obviously these other ones are going to, whenever this is going to contract right here, so जो निकल जाएंगे वो निकल जाएंगे, but the rest of them are going to come backwards again. Okay, so this process is known as retropulsion. So you have propulsion, grinding, as well as your retropulsion. Okay, very important. Now, obviously, we have the peristalsis wave. हमने देखा कि whenever the peristalsis wave occurs, you're going to have the opening of the pyloric sphincter, but this opening is very small. That is less than 2 centimeters. So that only the semi-solid chyme can cross the pyloric opening. Okay, very important. Primary peristalsis क्या है? It is again a continuation of your pharyngeal peristalsis, which was continuing ऊपर से, that is for your deglutition reflex. And secondary is mainly your local reflex जो हमने generate किया via the myntéric plexus, just like your what we talk about in esophagus. Now we need to empty the now we need to perform something known as the gastric emptying. उसके लिए we should know that there is something known as the pylorus which is watching as a guard, and it is protecting the opening of the stomach into the duodenum. Okay? So there are some factors which can increase gastric emptying and there are some factors which can decrease your gastric emptying. So what is the thing that can increase your gastric emptying is your decrease in fundic accommodation. अभी हमने बात की कि whenever this receptive relaxation does not occurs, in case of your vagotomy patients, what's going to happen is compliance of the stomach decreases, right? Compliance अगर decrease करेगा, that means intragastric pressure is going to increase. तो जितना ज़्यादा pressure increase करेगा into the stomach, obviously that's going to facilitate your gastric emptying. What next? Meal volume अगर less है, obviously अगर meal volume कम है तो gastric emptying जल्दी होगी. ठीक है? Liquids, whenever liquids, magentras जैसे हम कहते हैं, we study it in FMT, तो magentras के through they're going to travel. Ghrelin and hypoglycemia, all of them are factors which increase gastric emptying. What are some factors which decrease gastric emptying? The opposite. Increase in fundic accommodation. Something known as tachygastria. Just like we remember ventricular fibrillation, whenever we have ventricular fibrillation, we have lots of action potentials being fired, but are they any, क्या वो strong होते हैं? They're not strong at all, है ना? They're wasteful basically. So the same thing is happening in tachygastria as well. It's not it's generating enough amount of action potentials, but उनका जो contraction and that is very less. Okay, contraction of the muscle. What about pylorospasm? Obviously, pylorospasm is going to inhibit your gastric emptying. Increase in acidity, increase in osmolarity of foods that you're consuming. Fatty foods are especially prone to decrease your gastric emptying. Fibers have been seen to decrease your gastric emptying. Solid foods as compared to your liquids have been found to decrease your gastric emptying. So these are the different factors which contribute. Okay. Before we discuss something known as the migratory motor complex, okay? So we have something known as the migratory motor complex, we have something known as the peristalsis, okay? And we need to have a very important distinction कि दोनों में difference क्या है. First, we need to see is why is the need of a migratory motor complex, okay? So whenever someone of us would like to consume like chicken or non-veg in fat, so usme you have some cartilage, you have some bones, you have some stuff that you can't digest or break it down into chyme. So do you think that whole amount of stuff that you have consumed right now, जो कि आप नहीं ब्रेक डाउन कर सकते हो, वो वहीं पे रहेगा? Obviously not. So we need some clearance mechanism जिससे वो सारा का सारा stomach contents can go through the pylorus, even if the pylorus is saying मैं सिर्फ chyme को accept करूंगा. So obviously you're seeing one thing कि peristalsis में pylorus was only marginally open, but there is some mechanism by which the pylorus can get fully open and expel all of that content. So what is that thing known as? It's known as a migratory motor complex. Okay. We know peristalsis was always a continuation of deglutition, but this migratory motor complex does not have any correlation with your deglutition, and it occurs mainly on empty stomach. So let's discuss about migratory motor complexes. So migratory motor complex are what? These are the housekeeper of the intestine or housekeeper of the stomach in this case. तो क्या हो रहा है? They start from the stomach till at the ileum. Okay? And when do they occur? They occur in the post-absorptive phase after you have consumed your meals. So इनके तीन phases होते हैं. The first phase of migratory motor complex is non-propulsive. मतलब इस phase में nothing is going to be propelled out. ठीक है? So it's like a quiescent phase. So only slow waves are generated over here. We're going to see the diagram very soon. The phase 2 and phase 3, these guys are going to be propulsive. फर्क कितना है? Then phase 2 में that they're irregular contractions, and phase 3 में they're regular rhythmic high amplitude contractions. ठीक है? Phase 3 was seen by scientists to be due to some hormone known as motilin. Okay, motilin, and this phase 3 is the reason when we don't consume food for a very long time do we get hunger pangs, right? So hunger pangs is due to the phase 3 of the migratory motor complexes. So let's just see that diagrammatically. We saw phase 1 is the quiescence phase 2 is irregular contractions, phase 3 is regular contractions, high amplitude, okay, which were generating your hunger pangs. And what is this phase 4? Phase 4 is the basically your interval between your phase 3 and your phase 1. Okay, so this is the thing I'm telling you about. Phase 1 is quiescent. If you see phase 2 may, they're basically irregular, and in case of phase 3 you're seeing very regular high amplitude contractions. Okay, so these are the migratory motor complexes. So now let's talk about the small intestine motility. We know one thing is going to remain the same, that is the peristalsis. जैसे stomach में peristalsis होता है वैसे ही small intestine में peristalsis हो सकते हैं. Other thing that's going to remain the same is your segmental contraction. That's your mixing movement which you talked about, जिसमें दोनों ascending as well as descending segments are going to contract. और इसके बीच का bolus is also going to contract so that it's going to mix properly and it spreads out the food bolus. So what are the things which can increase your peristalsis of your intestine and can decrease your peristalsis of your intestine? What are the things that can increase your peristalsis of your intestine? I'm saying that is your gastrin, CCK, insulin, and obviously our friend, that is your motilin. What about stuff that can decrease your peristalsis of the stomach is? It's glucagon, distension of the cecum, as well as irritation of the cecum. Okay, irritation of the cecum that we see in appendicitis is the reason do we get this decreased amount of peristalsis and your constipation in case of your appendicitis. Okay, so the last thing that I want to discuss here in small intestine is something known as villi milking. Okay, so we know that there is a muscularis mucosa just below the just below the mucosa, and these things are basically thrown into this villi, है ना? तो ये villas की तरह form होता है. क्यों होता है? Basically due to the muscularis mucosa. So the theory goes like this: whenever the muscularis mucosa contracts and relax, this is going to like milk the lacteal. It's going to shorten the lacteal somehow, or mainly shorten the villi. Sometimes going to lengthen the villi. So it's going to be like milking movement. So that is known as villi milking. Okay. And whenever you're going to have irritation of the small intestine, you have some process known as your peristaltic rush. जिसमें पूरा throughout the small intestine you're going to have increased amount of peristalsis due to any toxin that you're consuming. Now we move on to the large intestine. Large intestine can be divided into two portions. That is through the half of the transverse colon. You have the proximal colon and you have a distal colon. Okay. Proximal colon is mainly for your absorption of your water and electrolytes. अब इसका मतलब ये नहीं है that it's going to have some specific transporters or something, aquaporins or something like that. It's mainly due to osmotic force. Okay, that you reabsorb the salt. As soon as you reabsorb the salt, the water is going to follow. Okay, so it's going to be due to osmotic forces. Whereas a distal colon and everything that is distal intestine की जो बात कर रहे हैं, that's mainly for your storage. ठीक है, and जो भी इसमें peristalsis वगैरह जो भी इसमें movements हो रही हैं, peristaltic waves हो रही हैं, they're very sluggish. Okay, like for the amount whenever this enters over here, इसको पूरा लगने में till it reaches the rectum, it takes about 8 to 15 hours. Okay, right. And we know कि there are some portions of the large intestine जो कि बड़ी specific हैं. First, it's 1.35 meters long and it's mainly made up of tinea. ठीक है, longitudinal muscles जो होते हैं tinea, and due to the contraction of the tinea, then you get something local dilatation जिन्हें हम क्या कहते हैं? Haustray. So they're between two contracting segments. Okay, and we have the appendicitis epiploicae as well. So these are the different portions which make up the large intestine. ठीक है, now large intestine में एक special kind of motility है that's known as mass contractions. They're known as mass movements. Okay, so they're going to occur 1 to 3 times a day. And why are they so special? Special ये है that they are very diffuse contractions. इसमें कोई haustrations नहीं बनेंगे. It's like 20 centimeters का portion of this large intestine is going to contract at the same time, singularly, as a single muscle. ठीक है, that's the thing. So these actions are known as mass action contraction, also known as mass movements. They occur for about 1 to 3 times a day. Okay. 1 to 3 times a day. So when does it occur? Usually this occur during the first hour of the meal. Okay? And this is a very important reflex, okay? Gastrocolic reflex that we call it as. Okay, whenever during the first hour of the meal, whenever you consume something, you're going to have an increase in the intergastric pressure because bolus aa gaya hai stomach mein and the pressure is increasing. What's that going to do is that's going to stimulate some afferents and that's going to activate your spinal cord as well as your main plexus. And uske through, what's going to happen is you're going to generate these something known as mass movements. Okay, mass movements. Okay, so like why are they 1 to 3 times a day? Because we basically consume about 3 major meals. So whenever these major meals are consumed, we're going to have something known as the gastrocolic reflex. Jiske through the bolus or the whatever the feces is there, that's going to transfer and deposit itself into the rectum for defecation. Okay. So duodenal colic reflex and your gastrocolic reflex are mainly due to your mass movements. Okay, very importantly, and the defecation reflex. Okay, so defecation reflex is mainly दो इसके reflexes हैं. या तो we can have a short reflex or we can have a long reflex. Short reflex is like a local reflex. Local reflex का मतलब क्या हुआ कि मान लो ये हमारे rectum है, and whenever you have distension of the rectum, we obviously know there's going to be something known as an afferent neuron. और वो afferent neuron क्या करेगा? जो ascending portion है, इसके ऊपर वाला portion है, उसे contract करा देगा. ठीक है, एंड व्हाट्स दैट गोइंग टू लीड टू? जो भी यहाँ का कोलन के कंटेंट्स हैं, दैट्स गोइंग टू लीड टू जो सारे के सारे कोलन के कंटेंट्स आर गोइंग टू गेट स्टोर्ड इनटू द रेक्टम एंड देन व्हाट विल हैपन अगेन? मोर डिस्टेंशन ऑफ द रेक्टम विल occur. So it's like a positive feedback loop. ठीक है, this is known as your short reflex. But does that initiate defecation? Obviously it does not. ठीक है, it's very weak. So actually defecation occurs due to a long reflex. Long reflex का मतलब ये है that's going to go to the spinal cord, go to the parasympathetic nervous system. Again, uske through you're going to have what? You're going to have relaxation of the internal anal sphincter. You're going to have your relaxation of your external sphincter. So your external sphincter is under your voluntary control. So whenever the situation fits in and whenever you want to defecate, then you can initiate that defecation. Okay? Right. So this is what I was talking about. How these afferent fibers are coming up and they're basically the pelvic nerve, that is your parasympathetic nerve urgentis जिसे हम कहते हैं, that are the parasympathetic nerve fibers. They're mainly motor to your colon. ठीक है, whereas the pudendal nerve is mainly motor to your external anal, it's mainly motor to your internal anal sphincter and that's going to inhibit it. Okay, very importantly. So this is what I was talking about. Now let's discuss something about the GI reflexes that we have. Some of them we have already discussed. For example, the gastrocolic reflex हमने discuss कर लिया है. So GI reflexes we have 3 types. Okay, one is integrated within the enteric nervous system. In fact, so जिसे हम कहते हैं local effects जो हैं, जिसके हमने बहुत अच्छे example पढ़ लिए हैं, that is your peristalsis or your mixing movements or something like that, है ना, receptive relaxation. Don't categorize gastric accommodation as an enteric nervous system. What is that? It actually getting integrated at the spinal cord. Okay, so gastric accommodation is a spinal cord it's a CNS mediated reflex, whereas your receptive relaxation that we talked about is your enteric nervous system mediated. What about some reflexes which are integrated at the sympathetic ganglia? That includes a gastrocolic reflex, जो भी हमने पढ़ा अभी. Then we have something known as the enterogastric reflex, and we have something known as the colonoileal reflex. Okay, so what is this colonoileal reflex? We're going to talk about the enterogastric in detail. We've already talked about the gastrocolic. We've already talked about the duodenocolic. Okay. What about this colonoileal? Colonoileal का मतलब ये है, whenever you have increased colonic filling, that's going to increase the colonic pressure. What's that going to do is that will decrease the ileal motility. So जो ज़्यादा contents है in the ileum, they're not able to go into the colon again. ठीक है? So colon से initiate हो रहा है and it's inhibiting the emptying into the colon by the ileum. That's known as colonoileal. Is it a short loop reflex? Yes, it's a short loop reflex mediated at the level of the sympathetic ganglia, but it's not an enteric nervous system वाला reflex. ठीक है? Then you have some other reflexes. Obviously, we have the defecation reflex, which is a prime example for your some reflex which is getting integrated at the spinal cord level or the brainstem level. Okay. So what is this enterogastric reflex? Enterogastric का मतलब entero मतलब your small intestine, gastric मतलब कि gastric के ऊपर कुछ reflex है. Okay. So what happening is it's originating from the duodenum and what's going to do is going to inhibit your gastric emptying. Okay. Inhibit your gastric emptying. So what are the different things that can stimulate this enterogastric reflex? First is distension of the duodenum. Second is irritation of the duodenum. Okay. Third, very importantly, is something known as the acidity of the duodenal chyme. Okay. Whenever we are going to talk about in GI hormones, whenever the chyme is going to enter, that is an acidic chyme which is entering from the stomach into the duodenum, then we have something secretion of something known as secretin. Okay. This secretin is the one which is actually mediating your enterogastric reflex and preventing further gastric emptying. जितना उसके बाद acidic chyme आ गया, वो कह रहे हैं मेरे को इतना काफी है. Now wait for some time, close the pylorus and decrease your gastric emptying. ठीक है? What next? We have increased osmolarity of the chyme, okay? And very importantly, presence of these certain breakdown products like proteins, peptides, वगैरह. Why am I saying that is whenever this is happening, like lipids or fat is being broken down, you have stimulation of something known as a CCK, cholecystokinin. And cholecystokinin क्या करते हैं? Again inhibits your gastric emptying. We've already studied, ठीक है? So secretin and cholecystokinin, okay? Right. So next we're going to discuss, we have already talked about the gastroenteric, we have talked about the gastroileal reflex, we've talked about the gastrocolic, we've talked about the duodenocolic reflexes. Then others one, we have something known as the peritoneointestinal or your renointestinal or your vesicointestinal. Matlab, whenever you have irritation of either your peritoneum or your kidney or your bladder, you're going to see कि जो peristalsis है, whether it be a colonic peristalsis or your enteric peristalsis, due to some mechanism it's getting inhibited. Okay, so these are the different reflexes that we've talked about. We talked about the gastrocolic, we talked about the duodenocolic, we talked about the enterogastric, okay, and we talk about these reflexes as well. Okay. So now we're going to talk about the secretions of the GIT. Okay, just see at a glance, कि saliva जितना हम secrete करते हैं, it's about 800 ml. Sometimes we call it as 1000 ml. Gastric secretion contributes about 1.5 liters. Pancreatic secretion is again 1 liter. Bile it's 1 liter. Small intestinal secretion, very important MCQ, is 1.8 liters, 1800 ml. And the large intestinal secretion is your 200 ml. So the total amount of secretion that we have is 6700 ml per day. Okay, so these are the ones which I want you to remember, along with their pH as well. Okay, so now we're going to talk about the salivary glands. We know हमारे पास major salivary gland, we have the parotid gland. Obviously, we're not going to go into the details of their anatomy per se, but just remember the parotid gland जो है, it's mainly a serous gland, and your remaining hand, that is your submandible and your sublingual, they may be your mixed glands. Okay, all right. So these are the different glands that we have. Please study their anatomy as well. What I want right now, and yes, remember, the parotid, how is it supplied? Very important thing. Parotid is mainly जो इसका जो nucleus है, that's at the present at the level of the junction of the pons at the middle oblongata. So this is known as the inferior salivatory nucleus. We have a superior salivatory nucleus as well, which plays a role as well. तो क्या होता है? Ninth nerve निकलती है through the jugular foramen. We know 9th, 10th, 11th exit through the jugular foramen, and this ninth nerve is going to send out a Jacobson's nerve that's in the ear. And uske through we're going to have a lesser petrosal nerve. This lesser petrosal nerve is going to exit via what? Is going to exit via foramen ovale, जिसके we think remember is via male, right? Mandibular nerve, accessory meningeal artery, lesser petrosal nerve, and your emissary veins. So this lesser petrosal nerve is going to go into the otic ganglion, which is present near the ear, and that's going to give rise to what? This mandibular nerve is giving rise to a branch known as the auriculotemporal nerve, which is supplying the parotids. Okay? And this thing which is coming from the lesser petrosal nerve is going to join in with the auriculotemporal nerve and supply the postganglionic parasympathetic fibers to the parotids. Okay? So whenever you talk about saliva, actually, this is an important MCQ. Saliva को stimulate कौन करता है? Actually, the sympathetic nerve system as well as the parasympathetic nerve system both increase the secretion of the saliva. Okay? But if someone asks you what is the predominant one, obviously it's the parasympathetic nerve system which plays a major role in your salivary secretions. But ऐसा नहीं है कि sympathetic nervous system नहीं play role करता. दोनों increase the secretion of your saliva. Okay? Right. And just like for the sake of it, submandibular जो glands है हमारे या sublingual glands है हमारे, they're mainly, how are they supplied? They're mainly supplied by the lingual nerve, right? That is why your chorda tympani branch that is being carried by the seventh nerve. Okay, that is your different supply. That is why the auriculotemporal nerve division of the mandibular nerve. Okay, all right. So this is what I'm talking about. Very frequent MCQ is कि saliva कैसे secrete होता है. Obviously we have something known as the serous cell or we have something known as the mucus cell, है ना? And उसके accordingly हमने secretions पढ़ी, whether they are mixed, whether they are serous, whether they are mucus. Okay. So what's going to happen is इसके level पे you have something known as the primary saliva का formation, and as you go along the duct you have something known as the secondary saliva का formation. Okay. Just remember जो primary saliva है, it's just like ditto copy of your plasma. So it everything which is there in the plasma. Is it rich in potassium? No. It's less in potassium. It's rich in sodium. It's rich in chloride and the like. Okay. So it's exactly similar to the plasma. So it's isotonic, right? Isotonic as well as very similar to your plasma. Now what's going to happen is as soon as the saliva flows down the ductal cells, you're going to see some changes. So let's see these changes as well. Okay. So this is what is happening. Isotonic abhi saliva hai. Now it's going to enter into the ductal cells, into the duct. Now what's going to happen is the duct is going to reabsorb sodium and chloride, and it's going to excrete your potassium and bicarb into it. Okay, a very important thing. It's going to reabsorb the sodium and chloride and secrete your potassium and bicarb. So this is your secondary saliva which you have formed after the ductal cell. So let's go in some more detail right now. So this is how it happens actually. So this is the acinar stage. First stage जिसे हम कहते हैं जिसके थ्रू हमें primary saliva मिल रहा है. Very rich. It has all of these products, right? But whenever we have the ductal portion में जो हमारी second stage of salivary secretion है, what's going to happen is sodium and chloride is going to get reabsorbed and potassium and bicarb is going to get secreted into the secondary saliva. Okay, and how is this mediated by? They sometimes ask you कि sodium जो है, it's mainly via active sodium absorption. ठीक है, because it's coupled with the sodium potassium ATPase, secondary active हम कह सकते हैं. Chloride is mainly a passive process. Potassium का secretion, again secretion हो रहा है, तो it's obviously an active process. And how is the chloride and bicarb is facilitated by the chloride bicarb exchanger, ठीक है, जिसे हम anion exchanger भी कहते हैं. Okay, so just remember sodium and chloride are going to get reabsorbed, whereas bicarb and potassium is going to get secreted into the ductal cells to form the secondary saliva. Okay, right. Just remember, अभी मैंने बताया parasympathetic nervous system as well as sympathetic nervous system both are going to stimulate your saliva. ठीक है, whether it be the parasympathetic via by the cranial nerve 7, that is in case of your submandibular gland or sublingual gland, and your ninth in case of which one, that is your parotid. Okay, whatever be the case, it's going to stimulate your muscarinic receptor, and through the IP3 calcium pathway, it's going to stimulate your salivary secretion. Whereas your sympathetic nerves, if they supply it, it's going to release norepinephrine working on beta receptor. That's also going to increase your salivary secretion. Okay, so now we move on to your gastric secretions right now. So just remember, this is what we call as a gastric pit, also known as a gastric glands. We have two types of gastric glands. अभी हम देखते हैं, ठीक है? And this is I've taken from pathology. Just remember that जो हमारे यहाँ पे gastric mucosa, it's obviously covered by a mucus, ठीक है? So we have three types of barriers. We have a pre-epithelial barrier, epithelium के ऊपर. Obviously, we have the epithelial barrier, जिसमें हमारे stem cells हैं, and we have a sub-epithelial barrier, which is mainly mediated by a mucosal blood flow, ठीक है? So what are the different protective? We're going to see that. Just remember, we have two types of glands over here. अभी मैंने क्या बताया? This is known as the gastric pit or gastric glands. So we have two types of glands. We have oxyntic glands and pyloric glands. Okay. What do I mean by the pyloric glands is they're going to contain two things. So they're going over they're present where? They're present near the pylorus. So what are they going to contain? They're going to contain two types of cells, either the mucus cells, okay, or the G cells. That is the gastrin releasing cells. Nothing else. Okay. What about the oxyntic glands? Oxyntic glands are going to, हमारे जो main stars हैं for gastric secretions are what? We have your parietal cells, which secrete your acid, or we have your chief cells. So ये oxyntic glands हैं. And you remember what is the different name for your parietal cells? They're known as oxyntic cells. So why are they known as oxyntic cells? Because they're present in the oxyntic gland. Okay. So the oxyntic gland are present where? They're present in the cardia, present in the body, present in the fundus. Where are the pyloric glands present? It's present over the pylorus. Okay. So this is what I mean by that. So you have something known as the mucus cell that's going to secrete mucus, whereas there's something known as the mucus neck cell. These are also your stem cells, and they're going to release bicarb, very important as a pre-epithelial barrier, and your trefoil peptides. That's again a very important pre-epithelial barrier. What about the parietal cells? Parietal cells are going to secrete two things: your HCl, that's your acid, as well as your intrinsic factor of Castle. And what does that play a role in? Plays a role in your B12 absorption. Okay. Then we have two types of cells, rather confusing. We have enterochromaffin-like cells, or we can have enterochromaffin cells. Enterochromaffin-like cells secrete histamine. That's going to stimulate your acid secretion. We're going to see that cooperative synergism. Or we can have enterochromaffin cells which secrete ANP. That is your atrial natriuretic peptide. Okay? So be mindful of that. What are they asking you? Chief cells, also known as your base cells, also known as your, which are present at the base, or your peptic cells, they may release your pepsinogen. Okay? And your gastric lipases, which are your predominant enzymes present over here. Then we have D cells, which secrete somatostatin, and obviously you have the G cells present where? In the pyloric glands, which secrete your gastrin. Okay? Just remember, whatever pepsinogen that we are secreting, it's mainly activated by your acid and broken down into pepsin, which is your, so every enzyme that we secrete, especially proteases, are all proenzymes. Also, we call them as zymogens. So they need to be activated. So in this case, it's activated by the acidic pH. And at which pH is it functional? Its pH functional है 1.8 से लेके 3.5 pH. ठीक है? It's a very narrow range. इसके through it's functional. ठीक है? So this is the gastric epithelial cells. How is it going to secrete your HCl? We know that at the blood, so this is the basolateral side, this is the apical side of your characteristic gastric epithelial cells. So at the blood side, at the basolateral side, what do we have? We have the anion exchanger. So what is it happening? Chloride को वो अंदर ले रहे हैं into the gastric epithelial cells, and bicarb को वो बाहर भेज रहे हैं. ठीक है? This chloride is again secreted into the lumen of the stomach, right? And what about the H positive? H positive is again being secreted by something known as the H positive, K positive ATPase. Okay, it's an active transport actually. It consumes ATP, which we call as a proton pump. Okay, so how is the H positive being generated? It's the same mechanism how the PCD does it via carbonic anhydrase present inside. The CO2 gets combines with your H2O to form carbonic acid, which breaks down into H positive and H bicarbonate. So just remember one thing, whenever we have gastric acid का secretion, ठीक है, we are saying कि H positive हम secrete कर रहे हैं, obviously bicarb is also going to be formed, and this bicarb is being carried into the blood, right? So whenever you measure the pH of the blood after you had a very hearty meal, you're going to see alkalinity in it. So that's known as an alkaline type. Why is it happening? Through the anion exchanger. कि H positive को excrete करने के चक्कर में जो आपने bicarb reabsorb कर लिया into the blood, that's going to increase the pH of the blood. So this is the mechanism why this happens. This is the gastric epithelial cells. What are the different things which can act on the gastric epithelial cell to increase the acid secretion? We can either have the vagus working via the acetylcholine. Acetylcholine directly acts where? It acts on the gastric parietal cells to increase via the M3 receptor. One thing. Okay? Or the vagus, what it can do is, the vagus can also stimulate something known as the enterochromaffin-like cells, which releases histamine, and that can act on the H2 receptor. That's again going to increase your acid secretion. Okay, दो mechanisms हो गए. The third mechanism is via G cells. These G cells are known as gastrin cells. Okay, they are gastrin releasing cells. So they release something known as gastrin, and this gastrin has its receptor, which is CCK, cholecystokinin type B receptor. Okay, and through it, it's going to increase acid secretion. Okay, and as I was telling you, it's not important. ये important है कि postganglionic parasympathetic nerve fiber, they don't only release acetylcholine. In case of vagus, they also release something known as your GRP, gastrin releasing peptide. So that is it. It's a new neurotransmitter, also known as bombesin in case of amphibians. So that's what gastrin release kara raha hai. We have histamine playing a role. What about somatostatin? Somatostatin is inhibiting acid secretion. Okay, so all of these stuffs are there. What about cholecystokinin and secretin? Again, that's your decreasing your acid secretion. Okay, so just remember all of these effects. So these are the contents of the gastric juice. We know we have pepsins, we have pepsinogens, right? There are no enzymes for carbohydrates, however. Okay, कोई carbohydrates की enzyme present नहीं है in the stomach. Okay, however, we have a gastric lipase which is present. Okay, in the salivary glands as well, we have something known as the lingual lipase, which is also known as the salivary lipase. पर वो saliva जब secrete होता है, that's alkaline. उस case में it can't act, so it needs an acidic medium. So now it has found its active medium. That is your gastric acid का जो pH है उसके कारण this lingual lipase also gets activated here. And obviously we know intrinsic factor and mucus तो वो release करा ही रहा है. Okay? So what are the different phases of your gastric secretion? There are three actually. You just have to remember the percentage and how is it mediated. You have something like the cephalic phase. Cephalic phase matlab when you are thinking about food, or whenever you have smelled some food, whenever you see some food, or whenever you have tasted some food, when you have initiated chewing, swallowing, before your gastric. It is not, the food bolus is not reached inside the stomach. उससे पहले जो आप acid secrete करते हो, that is why the cephalic phase contributes about 20 to 30%. And how is it mediated by? Via the central nervous system, via increasing the parasympathetic nervous activity. हमें पता है the vagus is going to release your acetylcholine that can work directly on the parietal cells via M3 receptors, or it can increase something known as GRP working on the G cells, and that's going to increase your gas. All right. The second one we have is the gastric phase. ये क्यों हो रहा है? Due to the distension of the stomach by the food. So whenever the food distends the stomach, that's going to elicit your local enteric nervous system reflexes, and उसके through जो भी acetylcholine release होगा, वो gastric distension के कारण जो भी हो रहा है, or it could occur due to some. So what happens is whenever these proteins get broken down into peptides and your amino acids, it's going to secrete your gastrin. It's going to be serving as a stimulus for your G cells to secrete gastrin, and that can mediate your gastric phase. And what about the last one? Last one is your intestinal phase. Intestinal phase में क्या है? You have some G cells present in the intestine as well, especially the duodenum. ठीक है? तो उसके through the gastrin can increase. ठीक है? Or what can happen is your absorbed amino acid, they can directly stimulate your parietal cells to increase your gastrin. So this contributes about 10%. So the majority gastric secretion जो है, that is due to the gastric phase. Okay? Followed by the cephalic phase, followed by least by the intestinal phase. So what are the different stimuluses that can increase your gastrin? Just remember, amino acids and peptides, that is your breakdown products of your proteins. Distension via enteric nervous system reflexes, we know that. Increased neural discharge via GRP, that is bombesin, we have studied that. Okay? And even your epinephrine sometimes. Stimuli that can inhibit gastrin secretion. What is that? Acid itself. Okay? Negative feedback mechanism. Somatostatin derived from the D cells. Okay? And secretin as well as CCK as well. We have not mentioned CCK. Okay? To CCK as well. Okay? Now we move on to your pancreatic secretions. Now we move pancreatic हमें पता है, we have exocrine portion and we have the endocrine portion. We have already discussed about the endocrine portion. We need to discuss about the exocrine portion. Exocrine portion, I want you to remember that there is two enzymes, something known as secretin. What does the secretin do is it stimulates your ductal cells of the pancreas to release more bicarb. So this is what happens. जो acids है हमारा उसने जो भी secrete करती है उससे छोड़ो. But basically when we talk about the ductal cells, तो डक्टल सेल्स के पास भी वही सेम ट्रांसपोर्टर है, दैट इज एनायन एक्सचेंजर, दैट कैन इंक्रीज योर बाइकार्बोनेट व्हिच इज अल्टीमेटली बीइंग कंपोनेंट ऑफ अ पैंक्रियाटिक जूस. ठीक है, तो secretin it increases your alkalinity of your pancreatic juice by increasing the this anion exchanger का function. ठीक है, so this is the main thing. And when we talk about the acini, they're going to so acini क्या करा रहे हैं? Acini mainly हमारे enzyme secrete करा रहे हैं, and mainly it's the ductal cells which are forming your pancreatic जो हमारे जूस secrete करवा रहे हैं. ठीक है, alkaline juice secrete करा रहे हैं bicarb rich. आसन है, वी कैन हैव पैंक्रियाटिक एंजाइम्स जो फॉर्म हो रहे हैं, दैट इज कार्बोहाइड्रेट्स के लिए वी हैव द पैंक्रियाटिक अल्फा अमाइलेज, फॉर लिपिड्स वी हैव ईदर लाइपेज, कोलाइपेज, कोलेस्ट्रॉल एस्टरेज एंड फॉस्फोलाइपेज, and proteins के लिए we have multiple, they're all released as zymogens which are pro enzymes. So what are they? They're trypsinogen, chymotrypsinogen, pro-carboxy polypeptidase, and your pro-elastases. So what happens is whenever trypsinogen enters into your intestine, when we know the pancreatic duct and your bile duct, it empties into the ampulla ovata at the second portion of the major duodenal papilla. तो वहां पे whenever it enters into the intestine itself, what's going to happen is वहां पे there is something known as the enterokinase which is present, and that can stimulate your activation of your trypsinogen into trypsin. Once trypsin gets activated, it's going to activate other proenzymes automatically. Okay, so this is what I was talking about कि secretin जो है mainly हमारा, just remember by acting on the ductal cells it can increase your bicarb. Okay, very important. Okay, so these are the contents of the pancreatic juice. We've already talked about the digestive enzymes per se. Okay, and again, phases of the pancreatic juices, again, it could be cephalic, okay, it could be gastric, but mainly it is intestinal, as opposing to the gastric. When we talk about gastric juice secretion, हमने कहा था जो main phase है that is your gastric only. इस केस में it is intestinal only. उस केस में it was 10% for intestinal. इसमें उल्टा है, ठीक है. Gastric is the least contributing, followed by your cephalic, and then intestinal is the maximum. Okay. So this is what's happening. We talk about trypsinogen, chymotrypsinogen, pro-elastase, and your pro-carboxypeptidase. ठीक है, उनके different organisms हैं, how they can cleave some amount of single amino acid. That is mainly job of your pro-carboxy polypeptidase A and B. It's an exopeptidase, मतलब protein के ends पे it is going to cleave into single amino acids. Whereas these trypsinogen or your chymotrypsinogen and all of these stuff, they're endopeptidase, मतलब प्रोटीन को ये बीच में से या पॉलीपेप्टाइड को बीच में से फ्रैगमेंट करेंगे. So amino acids are not going to form. We're going to form smaller amount of oligopeptides or polypeptides only. ठीक है, just remember the trypsinogen is converted into trypsin by enterokinase present in the duodenum, in the intestinal secretion, which we're going to see. Okay, and you remember the trypsin inhibitor that we talk about, that is your serine protease inhibitors of Cajal type 1, that is present in the pancreas, and that's serving as a very important inhibitor so that जो pancreas वो अपने आप को auto digestion ना कर पाए, and that is often mutated in some forms of hereditary forms of pancreatitis. Just remember that in surgery. Okay, so these are the enzymes, we've already talked about them again. So now we move on to the bile. Just remember, bile 1 liter. Okay, it's 1 liter per day. All right. So this is what happens. We know we don't need to discuss ourselves कि कैसे bile बनती है and all of that stuff. ठीक है. I would like we know about the lobules as well. ठीक है. Lobules के बारे में we don't need to discuss. And per se, gastrointestinal physiology में we don't need to even discuss about the different transporters which are defective in case of your bile acid secretion वगैरह. तो वो we are not going to discuss. We're going to straight away discuss about the bile acids per se and the bile pigments per se. So what happens is the cholesterol is going to form something known as the primary bile acid जो हमारे पास दो हैं. That is cholic acid and chenodeoxycholic acid. Okay, just remember that cholic acid, chenodeoxycholic. So whenever these bile acids, cholic acid or chenodeoxycholic acids, they can conjugate with either glycine or they can conjugate with taurine. So what can it form? When it conjugates with glycine, it can form glycocholic acid, right? Or it can form glycochenodeoxycholic acid, right? When it conjugates with taurine, obviously it can form taurocholic acid and vice versa, right? So these are your primary bile acids. However, this cholic acid can get converted into deoxycholic acid, and this chenodeoxycholic acid can get converted into lithocholic acids. So these are your secondary bile acids. Okay? Whenever these bile acids are conjugated with glycine or taurine, they're going to become conjugated bile acids. Okay? And whenever these acids are right. So we've already discussed about the primary bile acids and the secondary bile acids. So what is the function of this bile we need to discuss? Pehli baat, what is it going to do is, it's going to decrease the surface tension of the fat molecules. Once the surface tension decreases, जो ये fat जो बहुत बड़ा था, large droplet था, it's going to break down into smaller oil droplets. Okay? That's known as emulsification. Okay? What next is going to happen is something like this. Okay? So what do we see? कि fat droplets hai, they're going to emulsify into your smaller droplets. And now what's going to happen is these bile pigments, or not bile pigments, bile acids, conjugated bile acids, are going to form a micelle around it. Okay? And this micelle is ultimately going to lead to fat absorption. So what does it play a role in bile acids? Emulsification and absorption via formation of a micelle. Okay? So that's mainly thing. And just remember, this cholecystokinin, why is it named as cystokinin, is basically it can lead to contraction of your gallbladder. Okay? Contraction of gallbladder and your secretion of your bile. All right? Okay? Very importantly. So now we've already discussed this, and just remember, जो हमारा bile है, जो ultimately इसके जो bile acids हैं, they undergo a process known as intrahepatic circulation, जिसके through we don't want to waste them and we want to recycle them into the liver. So how do we mediate that? Is mainly via the terminal ileum, जहाँ पे they're mainly transported by active transport. Okay, all right. That's the thing. Now, the last secretion that we have is your intestinal secretion. इसमें बहुत simple है. Either they are the Brunner's gland, which are present in the proximal duodenum, and what do they release? They either release your mucus or they release your bicarbonate producing cells. Don't forget, small intestinal secretions, they contribute about 1800 ml, okay, per day. Okay. And what about the clips of Leberkuhn? We have these clips which run here. These are known as the clips of Leberkuhn present in the intestine. So they have the different types of cells. We can have enterocytes, obviously. That is your jo villi, brush-bordered epithelium wale enterocytes hain. We can have something known as your tuft cells. They are chemosensitive cells. We can have goblet cells. That is your mucus cells. We have your Paneth cells, very important immunomodulatory as well as your antimicrobial action of Paneth cells is there. And you have your enteroendocrine cells, which are different, which we're going to study in your GI hormones. Okay. Just remember, the colon is not going to have any villi. However, it's going to have crypts. Okay. So the crypts are present both in the small intestine as well as your large intestine. Okay. So one more thing that I want to remember about intestinal secretion is something about cholera toxin. Okay. So what this cholera toxin does is, this cholera toxin, it actually binds to this receptor known as the ganglioside receptor. Okay. Ganglioside. Why is it named as A and B? Because cholera type toxin is AB5 type of receptor. Okay. So the B5 subunit, that's going to bind to the ganglioside receptor, whereas the A portion is the actual toxin. So this cholera toxin. What's going to happen is this cholera toxin is going to, what is it going to do? It's going to stimulate your enzyme known as adenyl cyclase. That's going to release your cyclic AMP. And we know cyclic AMP activates a protein kinase known as PKA. And this protein kinase is going to activate a transporter known as CFTR. And what was the role of this cystic fibrosis transmembrane receptor is the efflux of chloride. So you're losing too much of ions here. And whenever there are ions, obviously water is going to follow by the paracellular pathway. So this is what I'm telling you about the mechanism how cholera toxin can mediate diarrhea. And the second mechanism through how it does is by the zona occludens toxins. So between these epithelial cells, you have these tight junctions which are known as zona occludens. So what this toxin does is it can cleave these zona occludens, and then paracellular pathway through both the ions as well as your water can flow into the lumen, and that can lead to diarrhea. Okay. So this is what we have discussed. The last concluding portion that I want you to remember is something about the chemotrigger zone. We know that एक vomiting center होता है, and there are multiple afferents which can stimulate it. Chemotrigger zone, जिसे हम उसे कहते हैं, right? So just read about that. कि जो chemotrigger zone है, that's also known as the area prostrema. And how is it different from different portions of the brain? Is it does not have any blood-brain barrier. Okay, so it's known as a circumventricular organ. Okay, so which ventricle is it associated with? It's mainly the fourth ventricle. Okay. So this chemotrigger zone, it basically, whenever it gets triggered due to any noxious substances or whatever, like chemotherapy, it could be pregnancy, that is due to beta HCG or whatever, what it can do is it can stimulate your vomiting center, which is present in the medullary reticular formation, and that can mediate your vomiting. Okay. The second thing that I want you to remember is regulation of your food intake. Okay. For that, we didn't read the hypothalamus per se, but let me just tell you, the lateral nucleus of the hypothalamus is your feeding center. Okay. But whenever you're hungry, your lateral nucleus is there. And your ventromedial nucleus is basically your satiety center. That will tell you to stop. Okay. So these are the things. And the mechanism behind it is very important when we discuss about like different genetic forms of your pathological obesity as well. Those case may have this, but we're not going to go into that detail. You can read it on your own. How does it do that? Okay. I would like, however, tell you about this very important mechanism via how the VMN functions. Okay. So this VMN is actually a glucoreceptor. Okay. So what happens is, whenever there is an increase in the blood glucose level, okay, that's going to enter inside the VMN via which transporter? It's going to enter via the GLUT4 transporter. That is insulin sensitive. Okay, And whenever this glucose enters inside the VMN is going to get active, and what it's going to do, it's going to inhibit the lateral nucleus, and उससे क्या होगा, food intake हमारा कम हो जाएगा, मतलब we have achieved satiety. However, in case when you develop diabetes mellitus, whenever you have insulin resistance and you have your downregulation of your GLUT4 receptors, when they're not able to work, what's going to happen is, what is going to happen? ये GLUT4 ये अंदर जा ही नहीं पाएगा glucose into the VMN, and hence it's not going to signal that there is adequate amount of hyperglycemia present. And what will happen? What have we seen in case of, what do you remember as the P's in case of a diabetes? We remember one as polyphagia. Okay, so that polyphagia is due to the dysfunction of these glucoreceptors which are present in the ventromedial nucleus. Okay, so increasing glucose is not being transfused into the ventromedial nucleus, and hence we continue to eat despite the hyperglycemia. So there is no satiety being retrieved. So that is the probable cause for hyperphagia in case of diabetes mellitus. Okay, right. So the last thing that I want to discuss, then we'll close the session, is we're going to have a short discussion on the different GI hormones that we have. Okay, so what are they? So families जब हम describe करते हैं, we can have the gastrin family that's composed of two portions, that is the CCK and your gastrin. Then we have the GIP secretin family, जिसमें obviously we're going to have GIP, we're going to have secretin, as well as we're going to have VIP, as well as something known as a glucagon related peptide. And then you have some other polypeptides like your motilin, which I want you to remember, ghrelin, I want you to remember, substance P we have already studied, and your GRP, that is your bombesin. Okay, so let's talk about gastrin per se. How is it released from? It's released from the G cells. Okay, and where were they present? They're part of the pyloric glands. You know, they're present in the pyloric glands. Where else are they present? They're present even at the duodenum and at the jejunum. Okay, what is the action and how does it work? It works via the CCKB receptors. हमने already पढ़ा है, because it comes in the gastrin family. So obviously gastrin and CCK are from the same family. Okay, so how does it do that? And what actions are it going to do? It's going to increase your gastric acid secretion by acting by CCKB receptors. We know that. Okay. What next is it going to lead to have a trophic action on the gastric and intestinal mucosa. Okay, it's going to have a trophic action, almost like a tumorigenic effect. It's going to increase your pepsin secretion as well. It's going to relax the pylorus. Okay, and it's going to decrease the opening of the lower esophageal sphincter. So what increases gastric emptying is your gastrin. Gastrin, it increases your gastric emptying. What about secretin and your cholecystokinin? That's going to decrease your gastric emptying. So let's discuss them. So what are the different stimulus for your gastrin secretion? Is mainly first is distension of the stomach as an enteric nervous system mediated reflex. One thing. Second is your product of your protein digestion. Whenever proteins you break down into peptides and amino acids, that's especially when it is aromatic amino acids like a phenylalanine per se, that's going to stimulate your G cell to produce more of gastrin, and that's going to increase the acidity further. Okay. Third, we studied about the gastrin releasing peptide released from the vagus. We talked about that, and calcium and epinephrine are just for namesake. Okay. What decreases gastrin? Actually, it is more amount of acid, excessive acidity, or we have somatostatin being released from the D cells. Okay, and we have GIP as well. Okay, gastric inhibitory peptide that can also decrease it, or we can have secretin as well. Okay, so these are things which are actually leading to it. We have vagal stimulation, non-cholinergic. We talked about it. That is GRP. We have products of protein digestion. We talked about that as well, and food in the stomach. That is distension of the stomach as well. Okay. Intestinal hormone, that is somatostatin, is inhibiting the G cells. We talked about that. Acidic secretion is also inhibiting the G cells. We also talked about that. And high acidic content, we have already talked about that. Okay. Remember pernicious anemia, and you remember Zollinger-Ellison syndrome. Okay. Pernicious anemia is basically an autoimmune attack against your parietal cells. They could be against different receptors of the parietal cells. They could even be against your proton pump as well. So different के against pernicious anemia होता है. And basically, उस case में the parietal cells are lost. So उस case में intrinsic factor is not getting released by the parietal cells as well. But then that is the reason why you develop megaloblastic anemia in case of pernicious anemia. And what is the Zollinger-Ellison syndrome? We know gastrin producing tumors because gastrin has a trophic effect, and obviously it's going to have increase in gastric secretion as well. Okay, so इसके कारण you're going to have multiple ulcers being formed at the duodenum. That is your Zollinger-Ellison syndrome. Then we have the second type of hormone, that is the CCK, cholecystokinin. It's released by the eye cells. Okay, they're not present in the stomach. They're present mainly in the duodenum and the jejunum. That's in the small intestine. Okay, and what is the CCK going to do? And how does it act? It works via the CCK-A receptors predominantly. CCK-B is for gastrin. CCK-A is for your enteric nervous system via the cholecystokinin. And what are the actions of cholecystokinin per se? It's going to stimulate secretion of pancreatic juice rich in enzymes. When I talk about bicarb, it's mainly secretin. When I talk about enzymes, it's mainly cholecystokinin. Okay, that is why we call CCK as PZ, and we forget the PZ sometimes. That stands for pancreozymin. And what do I mean by zymin? Inactive proteases. It's going to stimulate your increased amount of synthesis and secretion of your pancreatic enzymes. Okay, and the next job is cholecystokinin. So it's a cystokinin. That means gallbladder contraction is also going to be facilitated by CCK. Okay, so it's going to lead to what? It's going to facilitate the flow of bile and pancreatic juice into the intestinal lumen by gallbladder contraction, as well as we need this relaxation at the sphincter of Oddi as well. So both are mediated by CCK. Okay, what are its effects on CNS? I want you to remember that mainly produces anxiety. It can produce analgesia, and it has an anorexogenic effect. Okay, it's going to suppress your hunger. Okay, and as you remember, both secretin and your CCK, they inhibit your gastric emptying. Okay, very important. What are the factors which increase CCK? Pancreatic enzymes क्यों हमने बनाए थे? To digest fat, and hence products of fatty acid, products of fat digestion, like your fatty acids, your peptides, amino acids, and all, they're going to secrete your CCK, just like gastrin was being stimulated by your tryptophan and phenylalanine. Okay, right. So this is what I talk about. They're released by the eye cells. Now we talk about secretin. Secretin was the first hormone to be developed, which was discovered by Bayliss and Starling. And उसके लिए उन्हें Nobel Prize भी मिला था. And what is the source? Again, the source is the duodenum, jejunum, and the ileum. Okay. And what does secretin do? Secretin secrete क्यों हुआ? Due to the acidic chyme. So whenever the acidic chyme, it jumps from the stomach into the duodenum, it's going to be sensed by these cells, and they're going to secrete this secretin. So acidic gastric juice is a stimulus for the secretin, as well as your protein or products of protein digestion. And what is it actually going to do? These are cells which secretin secrete हुआ है. It's going to mainly lead to bicarbonate-rich pancreatic juice. By stimulating what? By stimulating the ductal cells, not the Asana cells. Asana cells was job of the CCK. Okay? And it's going to decrease your gastric acid secretion, and it's going to decrease your gastric emptying, as we've discussed previously. What about this GIP? GIP is released by the K cells. Okay, this stands for a multiple amount of things. It has a different बहुत सारे नाम है इसके. The thing that I want to remember, it's also known as GIP, that is gastric inhibitory peptide. मतलब it's going to inhibit your gastric acid secretion. And इसका जो एक और नाम है, that is glucose dependent insulinotropic peptide. Okay, so why do I see that is, when we discuss about endocrinology, we discuss about the incretin effect. Whenever we take glucose orally, that can lead to increased amount of synthesis of and release of insulin, as is expected when you give it intravenously. That was why the incretin effect. So incretin effect was due to two peptides. Either it was due to GLP, which we're going to discuss, and now we have studied this also due to GIP, that is glucose dependent insulinotropic peptide, also known as gastric inhibitory peptide. Okay, so this was that I showed you there as well. The GIP is released by the K cells, and your GLP-L4, they're released by the L cells. Okay, so then we have the VIP. हमने VIP बहुत अच्छे से पढ़ा in the enteric nervous system as well. Okay, and what does it do? It mainly relaxes. You know, VIP, nitric oxide, these were inhibitory neurotransmitters. But it's also going to lead to dilatation of the peripheral blood vessel, as well as stimulate intestinal secretion. Okay. Right. So we have other peptides. Motilin का हमने बहुत important role पढ़ा. That was in the phase 3 of your migratory motor complexes. Okay, phase 3 of MMCs, and they were partly responsible for your hunger pangs, as we saw. Just remember erythromycin. Okay, erythromycin is an antibiotic, obviously, and it can stimulate your motilin receptors, and that is the reason why this erythromycin can lead to diarrhea. But you can use this erythromycin in someone who is suffering from gastroparesis. Okay, so that is the effect of motilin by stimulating the motilin receptors. All right, so we have seen this. So this is a summary. As we can see, you can go along it as well. So this is what we are seeing. कि gastrin कहाँ से release हो रहा है? From the antrum, duodenum, and jejunum. And most of the CCK secretin वगैरह जो हैं, they mainly release from duodenum, jejunum, and ileum as well. तीनों sides से. Okay. So somatostatin, we know it's mainly by the delta cells. कहाँ present थे? Mainly they were present in the gastrointestinal mucosa. And what were they doing? Somatostatin हमें पता है, it's a growth hormone, inhibitory hormone. But इस case में इसका job was to inhibit the G cells and separate the acid secretion. Okay, and how is it stimulated? It was stimulated by acid itself. Okay, to prevent excessive acidity. Okay, so that is the main of somatostatin. So it's going to inhibit secretion of gastrin. It's going to inhibit everything else as well, secretin, GIP, VIP as well. Okay, peptide YY. Okay, peptide YY का भी बस main चीज ये याद रखनी है, that mainly decreases the motility and it decreases your gastric acid secretion. Okay, all right, right, and the last one. And then we'll conclude the session is ghrelin. So what does ghrelin stand for? It stands for growth hormone release. Okay, so ghrelin इसका मतलब यही है ghrelin का. And what is it? It's mainly a very potent orexogenic. Okay, so mainly lateral nucleus वगैरह से ghrelin वगैरह. Ghrelin is released from the stomach whenever you don't eat. So ghrelin that is released from the stomach, that's going to stimulate your lateral nucleus and tell you to eat. Okay, so that is your ghrelin. So it's orexogenic. And ghrelin, as we saw, it's also a very potent stimulator of your gastric acid secretion as well. Okay, so just have a look at the chart as well. What are the different factors which increase or decrease gastric acid secretion? Substance P, remember, it's an excitatory neurotransmitter. So it's going to increase the motility of the small intestine along with your acetylcholine, as we have discussed previously. All right. So, yeah. So as we know, E. coli, you remember the stable toxin of E. coli that can stimulate your guanyl cyclase, that can increase your cyclic GMP, and that can also lead to diarrhea, just like your cholera toxin. Cholera toxin, however, stimulates your cyclic KMP. So with this, we have already covered about 150 slides of a gastrointestinal system, and we are coming to a close. I hope this session was helpful to you guys, to everyone who's watching. And I would like to conclude this session today. If you have some questions, you can type them up, and I'm be ready to answer. And with this, we are almost we are done with gastrointestinal system. We are done with nerve muscle physiology. We have done renal physiology. We have done some bits of reproductive physiology. I need to make that video as well for the rest portion of it. Okay. So if there are any questions, if you like the session, please give me a thumbs up. If you're still here, these sessions are obviously going to be saved for further reference. You can watch it at 1.5x or something like that. Thank you for sticking around. And if you like this session, please give me a thumbs up so I know that you have been attentive. So thank you everyone for joining. And today's session thoda sa lamba ho gaya, but I just hope everything is covered till here. Please don't forget to look at previous year MCQs as well as solving some Q banks. तो हमने major portion सारा cover कर लिया JIT physiology का. If there's anything left, that must be included in the tutorial notes only. And if it is not, then please jot it down as well. And I hope these tutorial notes are serving of some benefit to you guys as well, so you can have a look at them later on and maybe have a quick revision of whole of GIT, especially the GIT physiology. I have deliberately not discussed some portions of GIT like your iron absorption or your B12 absorption or your B9 absorption or something like that. So I thought कि वो redundant हो जाएगा अगर हम we discuss that in other sections which we're going to discuss in medicine as well. तो अभी I've mainly stuck to gastric motility जो कि is a very core concept in GIT physiology. ठीक है? So मेरा बस गोल आज यही था कि GIT में GIT motility and hormones नहीं छूटना चाहिए. उसके अलावा whatever is there is always secondary. Okay? So that is the main confusing portion. What I have seen in these types of OS, mainly metabolic function of liver, which is again a chapter given in Ganong only, that we will read when we're discussing the hepatobiliary medicine, right? या फिर surgery में. And whatever is there, whatever we discuss about Rotor syndrome or the Dubin-Johnson syndrome, different types of conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia, वो सब discuss करना, heme synthesis discuss करना, breakdown discuss करना, वो अभी कोई benefit का नहीं है in case of GIT physiology. Or it would have been बहुत लंबा चला जाता है ये session, ठीक है? So I've tried to trim it down, keep it to a minimum. So I hope you all can derive benefit from it, and you see these lectures maybe later on. I'll also see them later on as well when I have to revise. Okay, and I hope you do well. And please continue studying. Happy studying. And please feel free, even if abhi aapko lag raha hai thoda shy feel kar rahe ho aap to ask anything or not. You can obviously contact me directly on Telegram. If you join the Telegram group, it will be included in every video's description box. Sare ke sare links for our channel, for our Instagram handle, for our Telegram channel. You can go there. You can message either me, you can message Shubhangi, whatever be your jo bhi doubt hai aapka. Okay. If you want us to upload some specific videos, if you want us to upload some specific topics, we are very happy to do that as well. Okay. I'm going to conclude this session today. Thank you so much for joining, and I'll see you in the next one.